Thank you very much, Chairman, and thank you very much for the invitation, which gives me the opportunity to talk with you about herpes zoster. Herpes zoster vaccination, a vaccine to prevent pain? Well, yes, because pain management is my specialist area, but I shall be a little bit broader than just discussing pain as if it were the only important thing about herpes zoster. My disclosure, I would just add that I tend to be fairly independent with my opinions. Before our chairman has to raise more than at least two fingers to me, I hope to answer these questions. Firstly, what's the reason for wanting to prevent herpes zoster? And secondly, is it possible? The varicella zoster virus is an alpha herpes virus. The herpes tells us that it has the capacity after primary infection to form latency, and subsequently that it can reactivate to cause a secondary condition. But the alpha is also important because it puts it in the same group as herpes simplex, types 1 and 2, and these are the neurotropic herpes viruses. So there we are with the virus, and it's one virus, two diseases. The primary infection, varicella, chickenpox, most commonly perhaps a disease of youngish children, most commonly full recovery. But we all know that that's not always the case. It can be a very serious disease in certain circumstances. Reactivation, herpes zoster, shingles, in younger patients who are immunocompetent, it tends to be a painful rash, 10 to 20 days, followed by full recovery, maybe with a little bit of skin scarring, either hyperpigmentation or hypopigmentation. But in older patients and immunocompromised patients, we can see some very unpleasant and sometimes lifelong complications, of which postherpetic neuralgia is the most common. I mentioned that it is a neuropathic disease, a neurotropic disease, and this means that the latency is when it takes up residence, if you like, in sensory ganglia, but reactivation and neural transmission result in sometimes permanent changes to the skin architecture as far as neural activity is concerned. Similarly, in the primary afferent nerve, the distribution, the ratios of small diameter fibers to large diameter fibers can vary radically. When we get to the ganglion, we can see a large amount of the normal neural tissue replaced by scar tissue. And when we get to the spinal cord, the dorsal horn on the side that is affected, in the dermatome that is affected, can show significant atrophy. So it is a multi-level neurological invasion. Vis-a-vis seropositivity is an absolute prerequisite to development of herpes zoster. You cannot develop herpes zoster if you have not had exposure to the virus and it has become latent. And in nearly every, certainly developed country, we achieve 95 to 100% seropositivity by the time we become adults. So essentially, the whole adult population has the potential to develop herpes zoster, and I think we know from yesterday that approximately 1/3 of us will, and if we live beyond the age of 80, perhaps half of us will develop herpes zoster at least once during our lifetime. We saw a variant of this slide yesterday, but I just want to add that was a total population, and it shows age to be the important factor in increased incidence of herpes zoster. But About 10% of cases of herpes zoster are not directly related to aging. They are related to immunosuppressing either disease or treatment. And this paper, as it happens, is extremely recently published, and it looks at the odds ratio of developing herpes zoster according to a number of malignant diseases. And I think we're all well aware that myeloma is possibly the most problematic, with a very considerably increased probability, and we come down the range until we get to some of the solid tissue tumours, which cause very little increase in probability. But also there are other immunocompromising diseases, and equally important, the treatment that they receive to treat the diseases. And this just gives an indication. Here we have, in fact, incidence rather than probability, and in the total population, they found an incidence of 4.82 per 1,000 persons per year, but after bone marrow transplant, 43, massive increase, and various increases with other conditions, and I'm not going to go into the detail, but they are greater on the whole with treatment, which of course adds sometimes to the suppression. The other thing is, how many times can you get zoster? And here I'm talking really about the immunocompetent community, in that it's really quite common in severely immunocompromised patients to get recurrences. There have been lots of suggestions. I've always quoted the figure about 6%, so it was some relief when this appeared as a publication very recently. Here we have the demographics of the population, the age distribution of the population, male and female. Here we have the incidence of herpes, or the number of cases of herpes zoster, male and female, noting the female preponderance, which is a common finding in many published surveys. These were confirmed cases of herpes zoster with PCR, which show the same distribution, even though the numbers might be a little bit lower. But if we look at recurrences, it was indeed about 6%. Particularly in older patients, were recurrent conditions. And they also showed that the recurrence then reduces the risk of having a further attack of zoster, probably 30% below the baseline rate. Postherpetic neuralgia incidence, I want to look at a slightly different way. This type of graph, which is similar to the one we saw for herpes zoster incidence, is commonly looked at, but the problem is there's never been a definition, an official definition of postherpetic neuralgia. And it was only really recent studies, big studies like the shingles prevention study and the Zoe studies of the subunit vaccine, which have really established the fact that we have this 90-day significant clinical pain diagnosis. And many of these could be any pain that was present when the rash had subsided. And so I think we have to be very careful. And so I rather like this slide from Meister, which looks at the duration of pain after zoster in different age groups. And I think it's interesting that up to 6 months, the older we are, the upper 2 or 3 curves, we have a significantly higher chance of still having pain by this time. That's a 20% chance. Now, I don't think many of these were clinically significant pain necessarily. In other words, I'm sorry, I should have explained. Clinically significant pain is usually defined as a score of 3 or greater on a 0 to 10 scale for pain magnitude. And some of these would have been below that. But nevertheless, particularly in older patients, there is a significant proportion who still have pain at 6 months, by which time the curves are pretty flat, and you can be pretty sure it wouldn't be much lower at 12 months either. So it's important. Factors that lead to postherpetic neuralgia: greater acute pain severity, greater severity of rash, in other words, disease severity, but also older age. And we had a very nice description and discussion of immunosenescence yesterday, and I don't intend to say any more about that. There are other predictors which are of lesser significance, which I've just, for completion, added on this list. We must also remember that it is not, postherpetic neuralgia is not the only complication of herpes zoster. The other complications, which are often very serious, are of much lesser incidence. There are the neurological ones, of which obviously postherpetic neuralgia is one. We are becoming more and more interested in the possibility that the risk of stroke is increased in the certainly 6 months, possibly a year, following herpes zoster vasculitic type strokes. There are the cutaneous complications, the ophthalmic ones, which can be horrendous, particularly in patients with HIV. I remember terribly well when HIV was in its infancy for treatment. I remember a patient saying to me, he said, "Look, I've lost absolutely everything. To be blind as well is just the end, as far as I'm concerned." And he got retinal necrosis in both eyes as a result of shingles. So it can be extremely serious. Impact of herpes zoster on PHN, why we should prevent it, perhaps. The patient, family and other caregivers. Somebody has to look after and support these people who have herpes zoster and complications. The healthcare economy, and indeed employers, because retirement age is going up, and therefore far more people who get shingles will still be in the working age group. So there is a loss to the economy that way. We've already said, to which I quite agree, that it's very depressing to look at the concept that serious aging and immunosenescence begins from the day we're born. As far as I'm concerned, that's only nearly as depressing as Brexit, but we won't continue with that one much. Thomas Weinke from Potsdam produced this little conceptual graph. There are no data behind this at all, I should add. Oops, I'm going too fast. Gosh, how did I do that? We know these curves for, if you like, aging, the functions of aging. I would like to move this chap. The older I get, the more I'd like to move him a little bit further to the right.
Please do.
Thank you. But an attack of herpes zoster during the acute phase in older people, there is a considerable reduction in capacity for normal functioning. There's usually then some recovery, but Thomas has suggested, and I think he's right, that many patients will never return to the correct place for their age on these curves. So I think it can be a lifelong problem. I was involved, with many others, with the master's study, which was an observational study we undertook in Canada about 10 years ago. And it was a concept that was mentioned yesterday, which interested me, was fewer subjects, but far more questions. That was exactly what we did here. It was an observational study of patients developing herpes zoster over a defined time in a defined population, and they were all of the age of 50 or more. And they were asked an enormous number of questions, and very frequently, up until 6 months. And this is just a little sample of what we were looking at. There were quite a lot of other things as well. But the only data that I'd like to present to you is capacity for the activities of daily living and the proportion of patients with each activity. So we've got each colored curve represents one of the activities. 0 is the time when rash appearance occurred, and this is 6 months. And this was the whole cohort of 261 patients who developed herpes zoster. And I think you can see that there is a significant drop-off in the proportion of patients with significant deterioration in these areas. In other words, a score of greater than 5 on a 0 to 10 scale, 5 or greater, I should have said. And even at 6 months, there's still about a 5 to 8% of patients had these problems. But if we look at the PHN group, separated out from these, we see that PHN starts right on day 0. There was far greater diminution in capacity for these activities right from the start, and as we proceed, we have over 10% still having the incapacity at the end of 6 months. So postherpetic shingles is bad enough. Postherpetic neuralgia adds a lot to the problem. Work and productivity loss, I'm not going to go into detail. I think you're all probably aware of this difference between absenteeism, in other words, not able to work at all, and presenteeism, you go to work but you're very unproductive. And it works out if you combine them, slightly different in the different age groups. But essentially, there's 3 weeks-ish of using 40-hour weeks, there's 3 weeks-ish of significantly reduced productivity following herpes zoster. That's kind of expensive. Then there are the healthcare resources. There's primary care, specialist care, drugs, hospitalization. Again, I'm not going to go into this in detail, but postherpetic neuralgia is considerably more expensive than herpes zoster alone. The largest cost is medications. Here, undoubtedly, it's antiviral drugs. In the postherpetic neuralgia, it's the gabapentinoids, well, the tricyclics hardly count because they're pretty cheap, and opioids. But I'm going to talk a little bit more about those groups of drugs in postherpetic neuralgia a little later. And hospitalization was discussed yesterday, and we saw that it's very expensive. This was a British study. We have a population, or did then, of about 60 million, and the cost of hospitalization was over £13 million in 1 single year. So it's quite an expensive disease. Then there is the problem of patients suffering, not so much their activity loss, but the fact they don't lose their pain as a result of our well-intentioned treatment. There are a number of drugs that have an effect, and in fact have a number needed to treat of 5 or less for treatment of neuropathic pain. But there are less than 50% of patients treated with these drugs for postherpetic neuralgia will get as much as 50% reduction in their pain. And the number needed to harm, which relates to adverse effects of the drugs, elderly population, a lot of concomitant medication. I was very influenced this morning by the problems of a dry mouth and the potential for the effects of that. The tricyclics certainly do that. Swallowing, cilial activity is affected by strong opiates. So the contribution of drugs to the problems of aging may be almost as important as the problem of pain. So we really, at best, get a modest benefit and some disadvantage. There is hope on the horizon. The International Association for the Study of Pain and its Neuropathic Pain Specialist Interest Group have shown that if we accurately categorize pain by quantitative sensory testing, which is a fairly laborious, skill-heavy type maneuver, we can predict better which patients will respond to which type of treatment and the NNT then goes up, and the side effect profile goes down. So there is hope on the horizon, and there are some new molecules which are being looked at which may be useful. Sadly, unlike other chronic pain, where cognitive behavioral therapy has proven to be probably the single most effective treatment, this is not the case as far as we can see for neuropathic pain in general, but postherpetic neuralgia in particular. So we now move to the vaccines, and you saw a very similar sort of sketch graph to this yesterday, and we have this concept of a totally unquantifiable threshold, and if the VZV T cell numbers are below that threshold, then you're susceptible to clinical reactivation. If they're above, you're protected. We can't measure that threshold, and it may even vary from time to time. We're born without well below the threshold, but we have humoral immunity against developing varicella from mum for a period of time. But sooner or later, most children are going to develop varicella. They get a good VZV T cell response, which then just gradually declines over the years. But varicella exposure boosts it, exogenous boosting, silent reactivations boost it, and the theory might have been, when people were thinking about vaccines, that maybe vaccination would act as a sort of surrogate for a herpes zoster attack and have a similar effect, in that we knew that herpes zoster was very protective against developing another attack. So that was the theory. So where are we? Well, we have one licensed vaccine, the Merck's Zostavax. We have one subunit vaccine that was described to some extent yesterday, which I imagine stands a very good chance of being licensed in the foreseeable future. The indications, probably both, we would expect herpes zoster and postherpetic neuralgia. The subunit vaccine, I would hope, would answer a need for a safe and effective way of vaccinating the immunocompromised community, who at the moment are left bereft of anything very much in the way of protection. That's not entirely true, because, for instance, with bone marrow transplant, the idea is you vaccinate the donor at an appropriate time before donation, so some of those cells will be carried across, and before starting anti-TNF drugs for rheumatoid-type conditions, the idea is to give the vaccination before starting the immunosuppressant drugs. So there are ways of cheating to improve the situation, but nevertheless, a vaccine that can be given to immunocompromised patients will be a significant advantage. We heard all about adjuvants yesterday, and we know from the discussion how potent this system indeed is. I don't think I need to bother about this, except to say that it is kind of useful in the older population if the vaccines can be given alongside, certainly influenza, which is given annually, and pneumovax. And this can happen. Just as a slight aside, I say how convenient it is. When we started the vaccination program in the UK, the assumption had been that it would be given alongside flu vaccination at the same appointment. That is not what has happened in most cases. GPs found that this was actually quite difficult, because this would be the first time patients were exposed to zoster vaccine, there was a long explanatory process involved, rather than the 30 seconds per patient that's allowed for influenza vaccine, because the patient has it every year. So most practices in the UK have a flu vaccination season starting in September going through to January or February, and then they start the zoster vaccination season February, March, April and onwards. So it didn't work out the way most of us, I think, expected. So What about comparisons? Well, it's easy and it isn't easy. It's easy in broad terms, and in fact, I'm going to do it in broad terms. But although the shingles prevention study and the ZOE studies both involved huge numbers of subjects, first of all, both were very well designed studies, and I have no doubt were very well carried out, there are some subtle differences. And also, as I'll explain in a minute, postherpetic neuralgia is rather difficult to look at in the subunit vaccine. So I'll try and, we saw some of the data yesterday for the subunit. But as far as Zostavax, the live vaccine, the attenuated live vaccine is concerned, the study in patients from 50 to 59 was a separate study to the original shingles prevention study. It was called the ZEST study, and we only know from the ZEST study what we know for the ZEST study. And they didn't look at postherpetic neuralgia, but there was a significantly higher efficacy than in older subjects, which I think came as no surprise. So there was a 70% protection against developing herpes zoster. And then if we look at the original large shingles prevention study, in the whole cohort over the age of 60 or 60 and above, 51% and the protection was quite high, up to 69, and then quite significantly lower over the age of 70. But if we looked at postherpetic neuralgia and burden of illness, which I haven't shown here, actually it was rather better. So attenuation took the place in some subjects, in a significant number of subjects, of absolute prevention. So it reduced severity, but didn't necessarily reduce zoster. Now, the extraordinary finding, as we heard yesterday, with the subunit vaccine is this enormous protection against herpes zoster. So there ain't much point in looking at postherpetic neuralgia because there weren't enough patients to really get it to any statistically manageable extent. So there was a very high incidence of benefit. Now, the adverse effects, as was discussed to some extent yesterday, is a rather different story. In the shingles prevention study and in some sub-studies that have occurred since, there are indeed adverse events, there are systemic adverse events, and there are local vaccine site events, as one would expect with any vaccine. In fact, you can see from the placebo groups with any injection, let alone a vaccine being present. But I think the most important thing, and I'm not too sure this is published, but my examination of the data would suggest that severe reactogenic events were very rare, in fact, possibly less than 1%. So, yes, reactogenic events occur, but the severity was pretty low. But if we move to the subunit vaccine, as was discussed yesterday, it's pretty high. Systemic events, active vaccine versus placebo, and these were the severe ones, the ones that tend to be called, I think, grade 3 or above, although I'm not a great expert on that. And the local injection site ones, this is for the two studies, the ZOE 50 and the ZOE 70, so patients above 50 and patients above 70. Well, let's just look at the ZOE 70. So 74% against 10% in the placebo group, and severe ones, 8.5%, as against 0.2% in the placebo group. However, 96% of subjects did attend for the second dose. Now, I accept that that is under study conditions, which isn't necessarily quite the same as real life, but it nevertheless indicates that they weren't totally put off by any reactions they may have had. And 91% of those with a severe reaction, return for the second injection. There was no increased reactogenicity after the second dose. So you could at least tell patients that it was very unlikely to be worse with the second one. In fact, it was less with intramuscular injection rather than subcutaneous. And the serious adverse events, deaths and all that sort of thing, were actually very similar in the placebo and the vaccine recipients, which was exactly the same with the live attenuated vaccine. And I think I'm right in saying that so far there's been no evidence of increased autoimmune diseases or exacerbations of such things as a result of vaccination, which was a fear with an adjuvant as potent as the adjuvant that has been used. So where are we? I may or may not discuss this. Those were efficacy studies. But of course, you can only do effectiveness studies when you look at the real life situation of a vaccine program that is licensed and is on the market. And we haven't reached, obviously, that stage yet with the subunit vaccine. We have with the effectiveness vaccine. But before I thought that might be the case. So before I get the second finger, that was only one, wasn't it? Before I get the second finger, I will say that we are at the situation where we have a subunit vaccine that is exceedingly effective in all ages at preventing herpes zoster, and hopefully will be applicable to immunocompromised subjects, but it requires 2 doses, and we know from other multi-dose vaccines that the rate of return for the second dose is reduced somewhat. So that may or may not be a problem. It will depend on education, I have no doubt. And the vaccine is significantly more reactogenic. But that's how we are. And all of us, I think, will have our own perceptions of what we would take into account and what decision we would come to for ourselves and maybe in our advice to other people. The only thing I'm going to say then about the effectiveness study, large study after a vaccine program had been instituted, conducted by Kaiser Permanente, who's the healthcare organization, massive database of patients over the age of 50. They provided for their members Zostavax free of charge, or they paid for it, and essentially the results totally support the results from the shingles prevention study, not statistically significant, but in some cases slightly better. But essentially it is effective to a similar extent that you would hope for from the efficacy study. I'm not going to go into the details. I've explained the equivalence, really. Programs, just very, very briefly. I'm only going to talk about the Zoster program in the UK. The government agreed to fund vaccination of elders between the ages of 70 and 79. They chose that figure because they felt that the cost effectiveness was only going to be satisfactory in that age group because they thought it unlikely that that age group would require revaccination. So this relied on there only being 1 dose of vaccine given. In the first year, we were only able to vaccinate patients aged 70 and 79. It sounds stupid, but there was a shortage of vaccine. The general practitioners who provide virtually all our vaccination in the UK didn't feel that they could really cope with the whole 10-year cohort in one go, and I don't think the government thought they could pay for it either. And there was a very high uptake, 61.8%. I think that's, pretty impressive at the 70-year-olds and just a little bit lower in the 79-year-olds. The second year, a bit of a reduction. In the second year, they actually did 3 age groups, 70, 78, and 79, to speed up the rate at which we would reach full coverage of the 10 years. And then last year, again, a slight fall, but not huge. And I don't know what's going to happen next year. Now, the answer is yes to the first one. It's worth preventing. It really is worth preventing. Now, the answer to my second question is yes or no. Now, why the no? Well, the reason for the no is because even if the vaccine were 100% effective, the proportion of the at-risk population that is likely ever to receive it is actually quite small, worldwide population. Therefore, it will answer the needs of those who have access to the vaccine, but it leaves a lot of people who will not be offered that protection. So we should not stop the search for drugs that are effective in managing herpes zoster and in particular its complications. So thank you, and I'll leave it at that.
Thanks for your excellent speech. I just have one question about the recurrence of zosters. Because I will face some patients have their first zoster reactivation maybe weeks or months ago. So would you suggest them to receive the Zostavax for prevention or to reduce their pain? Otherwise, when would you suggest them to receive this vaccine?
Thank you for reminding me of that. And in fact, it's been quite a problem with our program in the UK, because if a patient missed out on receiving it at the right age, there was every chance they'd never get the vaccine. So although I think optimally one should be vaccinated perhaps 3 years or so after having herpes zoster, we actually suggested in the UK that 6 months was perfectly all right. And so we vaccinated patients who'd had zoster only 6 months, and I suspect some who'd had it rather less time before. But we don't know, obviously, how effective it might have been at that stage. But there's certainly no safety reason not to, and I think because of the albeit relatively low recurrence rate, it's an appropriate thing to do.